we have found out that the membranes are not only those passive barriers, they are actually key players in the wound healing. Absolutely, thank you for the question. You know, when we started to explore the biological principle of GBR in late 80s, early 90s, we saw the use of the membranes pretty much as a barrier, separating different tissue types during the wound healing situation. We have found out that the membranes are not only those passive barriers, they are actually key players in the wound healing. So we prefer sometimes to call the membranes to be that they are actually bioactive membranes. And with this knowledge, we have also today the capability and possibility to modify the design of the membranes accordingly. So we see some interesting developments where we can basically tailor-made a membrane that is ideally suited both to improve the soft tissue healing as well as the bone healing in the GBR situation. Our idea was that the soft tissue and the bone tissue are two different tissue types, and they have very different needs during the healing process. What we actually did with the Neogen membrane is that we have towards the bone surface, we have a little bit more open structure of the membrane, which allows a passage and interchange with certain specific growth factors that they will actually accumulate within the membrane and being there and being released, a little bit like a sponge, so to speak. The ePTF membrane has a little bit more sophisticated structure. It's more of a three-dimensional fiber structure, and the reason for having that structure is that structure with the fibers are much more attractive for cells to attach to. We have seen in our studies that especially fibroblasts on the soft tissue side has difficulties to survive on this dense PTFE in contrast to the ePTFE. And I think this is something that is, from a clinical standpoint, important, that you have a solid, good soft tissue healing on top of the membrane and avoid exposure of the membrane.